or centers of service delivery. So also screening by itself for us, let's know that this is not a preventive value when patients are not linked to treatment. So it is an initiative that needs to be having a close-up loop so that all these patients who are being screened are given the care they deserve at that level, or given an appropriate navigation so that we complete the whole loop for this patient to be attended to in time. That's when we can now validate screening. Again, in terms of coming up with this protocol on screening, a lot of considerations came into place. And one of the considerations we're looking at is about the acceptability, desirability by patients and even the community. We're also looking at the historical precedents for screening and sufficient burden of these diseases, and cervical cancer being one of these burden of diseases. Apart from acceptability, we are also looking at the epidemiological consideration, or what some people call medical consideration. And here we are looking at the disease distribution, the natural history of the disease, availability of the tests, acceptability again in terms of epidemiological consideration. Also going ahead to look at proven screening programs, which have really helped us to come up with new techniques that help us to screen our clients at the sites. Also being considered during coming up with this protocol was the resource consideration, so that in lower levels, we are not able to perform HPV, for example. There's something like VIA to be done at that level. We're also looking at quality assurance, and all these were considered during coming up with the guideline. So let me now go to the risk factors. I know we have gone through this severally, like for example, early initiation of sexual intercourse below 18 years, having multiple sexual partners who can continue spreading high-risk HPV and so on, having sexual partners with multiple partners, again, putting us at high risk, co-infection with other sexual transmitted infection. And this is also key for us as people who perform screening on the ground. Most of the time we rush and just do examination on the cervix per se, and forget about taking just a few history about possibility of having some of the sexually transmitted infection, which can be also part of a problem to a presenting participant or a presenting client at that time. Again, putting us in higher risk is about multiparities, though this still under a lot of research, immunosuppression due to HIV and other infection that can lead to disturbance with immunity. So it's not only HIV per se, but us as screeners, as we look at the screening frequency and so on, let's consider the population of HIV infected individuals in terms of having higher risk of having persistent HPV infection, and therefore 6 times more at risk. And we should consider screening them appropriately and with the correct schedules. Tobacco use also picked as one of the risk factors within the community. So screening methods, as per the protocol and the new protocol we have, not much changed apart from the what we need to have as the standard code. So one is about molecular testing. And I know this was also advocated for in the last protocol, that is for the protocol 2018 guideline. And from small analysis done by that time, we had around 73% of screening being done via VIA, 4% cytology, and only 2.5% being done as HPV. So from that small analysis, we celebrate those who participated in terms of providing treatment for precancerous lesion using cryotherapy, the thermoablative devices, and this really improved in the program of See and Treat. So again, from this protocol, we are still advocating for HPV as a standard gold, and we are advocating for this as one of the high performance tests which we need to integrate into our service. And the age here, we are looking at women above 30. This one remains. However, in terms of having some of the consideration, I know there's more guideline on this, cutting across the ACOG, CCP, SGO, looking at ages where we can start doing the HPV, and they are considering even up to 21 years of old. However, we have seen from occurrences that even the age below 30, having CIN3 plus and above is minimal as compared to those above 30 years of age. So in terms of protocol, you still have a 30-year age mark as the recommended age for HPV examination. So apart from HPV, we also have visual inspection with acetic acid. I know we normally used to integrate this with VILI, but again, looking at the cost and also how we keep the VILI in our clinic, most of the time it was being left open with a lot of light, degrading its competency, and therefore we could not get good results with the VILI. So still, VIA has proven to be okay in terms of doing screening, and we advocate VIA only for screening because of the reason stated. So where HPV test is not available, please don't say we are not screening because the gold standard is HPV. If we still have availability of acetic acid, let's continue screening and navigate appropriately. So with using acetic acid from the primary level facilities or higher level facilities without HPV test, kindly let's continue and provide the care per se. Again, we also have cytology. This is looking at the pap smear, also recommended as a primary screening method, and mostly in the following situation. For example, women who are not eligible for VIA because of the type of the transformation zone. And we talk about the type of transformation zone. I know most of us who screen knows about this. We also normally have type 1, TZ, type 2, type 3. And this is based on the ability to classify where we have the transformation zone. And you can also differentiate the columnar, the squamous region. You can see it in totality. Then you say this is type 1 transformation zone. For the type 2, you can just see partially where we have the TZ separating the columnar and the squamous. Then type 3, you can't see totally the differentiation between the columnar and the squamous, and therefore doing VIA to such a client will not give you a proper result. And also in terms of having the technique of speculum insertion and placing speculum in the right position is very key for us when we screen using VIA. For example, if the client is having a full bladder, is having full rectum, these are the things interfering with the techniques of speculum exam, and therefore we need to provide structures within our area of work so that these mothers are able to have good structures which will enable them to empty their bladder, empty their rectums, and therefore makes it easy for speculum examination. Again, for these clients who are type 3 TZ, let's consider doing cytology so that we have good results. Cytology has also been used as a primary test in women between the age of below 30 years of age for diagnostics, and therefore this is also allowed. Then who to screen and what is our screening frequency? So any woman who has ever had sexual intercourse is eligible for cervical cancer screening. So here, this one doesn't determine the age, but only look at when was the sexual debut started, and now they qualify to be benefiting from screening. So let's also screen such a population without difficulty. So in Kenya, in terms of pragmatic purposes, we normally target population of between age 25 to 49, what we call the screenable population. Let's differentiate this with the women of reproductive age, because if we look at the women of reproductive age, the age bracket comes a bit lower as compared to screenable population. So if we talk of screenable population, it's between the age of 25 to 49. But still bear in mind, any woman who has ever had sexual intercourse qualifies to be done cervical screening. Again, what we are advocating for in this protocol is about integrating the service of cervical cancer screening and clinical breast exam. So all women will come with breast to us as we do cervical cancer screening. Please let's palpate for any mass, let's examine for any color change. Let's teach them on how to do monthly self-breast exam. Let's also schedule them to come for clinical breast exam, which is normally yearly at least, so that we conquer the two. Remember, in terms of incidence, breast still now overtakes cervical cancer is number one. So we want to integrate all these services so that we do it at one-stop shop. Then HPV testing is recommended for primary screening method. So screening frequency, how do we do it in the new protocol? For HIV negative, we do every 5 years when we do HPV and the test is negative. And for those who are being tested with VIA, we do it every 3 years. For the last protocol, it was 5 years. But again, about more of the discussions about VIA being subjective and so on, we realized that let's do it at 3 years at least for those who are HIV negative and VIA used as a method of screening. Then remember 5 years, negative HPV test, HIV negative, that's the frequency. For HIV positive, every 3 years if HPV test is negative, and annually if VIA is used. So let's keep that in mind. So who to screen and what is our screening frequency? So women aged 50 and 64 years, screening every 5 years using HPV and cytology. Then women above 65 years, screening is not recommended, but what we normally advocate for is if you suspect any sign, it is good to just do a simple speculum examination just to visualize and not to miss anything. However, we are not applying any VIA at that time or taking HPV test, but still we need just to do a simple speculum exam and try to pick something which may attract your attention at that time. In pregnant women, we normally say first trimester only during first trimester, but do not treat. If there is a lesion in a pregnant woman at first trimester, just postpone this and resume after 6 weeks post-delivery. Then postpartum women screening can commence 6 weeks after delivery. Then looking at the algorithm, just to summarize on HPV negative, let's screen after 5 years, and for HIV negative population, and if HIV positive, remember it is 3 years. For HPV positive, I know we have even the handheld small colposcopes within our facilities. Let's try to do colposcopies so that if we have done colposcopy and it is positive, then we know how to do biopsy. For those who are positive with the colposcopy examination, let's do biopsy and take the best sample through colposcopy guided process. For those who don't have colposcopy, still don't say this is HPV positive, I don't know what to do. No, you have something to do. Even without a colposcope, go ahead and do VIA. And if VIA put speculum suspicious, just refer appropriately for biopsy and further management. If VIA is positive and eligible for thermoablative treatment, for example, lesion not more than 75%, provide thermoablation at that point. If you're not eligible for thermoablation, maybe the lesion is more than 75%, or the lesion is extending intracervically, then this is a candidate for LIP. Refer appropriately, or if you have LIP, let's do LIP at the site and send this sample for further histological analysis, just to examine the margins to see whether you have cleared everything. If the margins are still positive, still allow second LIP, though some of the preference has been doing cone biopsy, just to make sure we have come out with all the lesions. If the VI is negative, just repeat after 1 year. If colposcopy is not done, but HPV is positive and have done VIA is negative, let's screen within a year so that we don't miss anything when the HPV is positive at that time. Then for those who are HPV positive and colposcopy positive, let's do biopsy. Let's try to take the most appropriate site. For example, if you see where we have the punctations, you are able to differentiate where you have the you are able to differentiate or have knowledge on mosaicism, the blood vessels which are suspicious. That's the point to take biopsy and run this for histological analysis. So for VIA, naked eye enhanced, I know some of the facility do VIA under colposcope, which is also a good practice, but if you don't have a colposcope, do VIA with the light. Positive, kindly do thermoablation or treat if the lesion meets the criteria. And for those who do thermoablative procedures, if the participant is having co-infection with the in the cervix with cervicitis, kindly treat first before you provide thermoablative procedures or radiotherapy. And if eligible for not eligible for thermoablation in one way or another, in terms of the size of the lesion or the characteristic of the lesion, for this patient for treatment with the LIP procedure. And if we have seen less than 3 with negative margins, that's the best outcome for LIP, which we expect. Then if you have suspicious for cancer, kindly don't go ahead and put VIA and so on, just refer appropriately. And if you have a tissue biopsy in your area of work, go ahead, take sample and send for processing. That is histology. Then for cytology, if you do cytology and it is ascars, let's immediately try it with HPV. And if it is HPV negative, it is screened after 3 years. If it is positive, let's still do colposcopy. Depending on the outcome, positive, let's do biopsy. If it applies, it is negative, it is screened after 3 years. And if colposcopy is finds out to be having suspicious, let's also refer appropriately or take biopsy at that point and navigate that tissue for histological analysis. Key points: screening all women in the target age group, followed by treatment of detected lesions, can prevent the majority of cervical cancers. So remember, screening is not only screening and leaving that woman. It will not help. So you screen, treat, or navigate for appropriate care. That's when we close the loop. So every woman in the target age again, that is 25 to 49, should have cervical cancer screening test performed at least once. Most benefit as compared to those who don't go through this. Then screen and treat approach recommended. No, majority of healthcare providers from various centers, including lower level facilities, have been taken through the screen and treat program with the NCCP, and people have the right knowledge on how to treat. So let's try and identify more women in terms of increasing the screening numbers so that we get women who have lesion in the community, give them treatment, and our women will be safe. In terms of decision on which screening and treatment approach to use, in our particular facilities, let's also base this in terms of treating so that we don't have potential loss for follow-up. I know if we don't treat in time, cost will be much on us, directly or indirectly. So let's do something just to equip our community with the appropriate information so that this can continue without bottlenecks. So any suspected cancer case after screening should immediately be referred for diagnosis. If you say I've seen something like bad lesion and you don't take care of that woman at that time, then that is a disservice. So any suspected case, even if you're not sure, kindly write suspected and refer. It's not an offense. The next person will also take over from there. Then writing I'm not sure, then write negative. If you're not sure, just write positive and refer appropriately. In terms of clarity on the information about HPV, remember it is not a confirmation of cervical cancer. So if you are using HPV and you are relaying information about the result, kindly tell these women the right information that this is not cancer so that they don't go back to the village and start treatment from the herbal and so on. So let's give the right information of what HPV test positive means and what's the next step of action that we complete the loop again. So HPV is also a sexually transmitted infection, and however, a current positive is not a confirmation of partner infidelity. So when you're doing counseling about a positive HPV results, let's be very cautious on how we give this information and not tie it to partner infidelity. Then to avoid test result misinterpretation, gender-based violence, and so on, let's also avoid activities after lip or thumb ablation procedures just to make them heal well and proceed with the life as normal. Then a question to all of us is, what is the challenge? And I normally say a challenge is a gap between what the current performance is and what target we need to achieve. So you as a healthcare provider, look at your area of work, look at the current performance on how you perform in terms of screening, and look at the gaps which we need to fix at that point so that we reach the target. So the question to us is, what can you do at your level just to contribute to the elimination agenda? Thank you very much for listening, and in case of any questions, we'll be right here to answer. Thank you very much.
Thank you very much, Kennedy, for a very informative session. In case you have questions, please go to the Q&A section and write down your answers, and the panelists will be able to type their answer or answer live. At this juncture, I'd like to welcome Dr. Amina Hassan, who is a gynecologist by profession. She's a gyne oncologist at Garissa County Referral Hospital. And she is very passionate on issues related to cancer. Thank you, Dr. Amina Rashid. Sorry, Dr. Amina Rashid. Welcome.
Thank you very much, Dr. Mutwa. Good afternoon, everyone. So I will go ahead and share my slides. So I have no disclosures. Before I get to the burden of cervical cancer, I want us in the audience, we are almost 1,000. I want you to ask yourselves a few questions, very meaningful questions. And I want you to hold yourselves accountable today. Ask yourselves, have you ever in your life been involved in any awareness campaign for cervical cancer? One. And then you ask yourself, this is January is usually a cervical cancer awareness month. So have you participated in any cervical cancer awareness event? So then you can say to yourself, yes, no, and most of the times it's no, isn't it? And then you ask yourself, do you know that HPV vaccination is more than 90% preventive for cervical cancer? And it's like giving, a gift of health to the next generation. So you think of your children, think of your daughters, think of your nieces, think of your neighbors, think of their children, isn't it? And when you look into the future, what is your hope for the future in terms of women's health? When you look ahead, what do you see? When we look at the burden, we realize that cervical cancer rates have significantly dropped in the more developed world. And then you wonder, in our world, it continues to skyrocket. So you wonder why. Why are our numbers so high compared to the more developed world? What are they doing different? And before we say Serikali's idea, you have to own up, you have to stand up and take action, isn't it? So if you don't talk to your neighbor about screening, if you don't take your children for vaccination, if you don't go yourself to get, screened or vaccinated, then the future is very bleak, isn't it? So when you look into the burden, again, unfortunately, cervical cancer continues to be one of the most common cancers among the women. And GloboCan estimated worldwide, there were approximately 661,000. And you can see there's a rise. So the 604,000 is from GloboCan 2020. So there's a huge difference in terms of the numbers. And those are just new cases. So when you look at the deaths, you realize that more than half of the women die annually. So you can see 348,000 just the year 2022. When you look back to 2020, the numbers are way lower. Slightly lower, but they're way lower. 342,000. That is a huge difference. So this means that if you're diagnosed today with cervical cancer, you ask yourself, what are your chances of survival? Then have you had your screening so that you can prevent that? And again, the unfortunate bit is majority of the new cases and deaths occur in low middle income countries. So you can see 85% of the new cases, and you look at the 90% of mortalities that happen in LMICs, that happen in the world. 90% are occurring in LMICs. But then again, you wonder why, for a disease that is 100% preventable. So then you come down to Kenya and you ask yourself, what is really going on? You can see cervical cancer comes second, while in the world it comes 9, according to GloboCan 2022. In Kenya, it comes second in terms of incidence. So you have 5,845 women. But then again, when you look at the mortalities, it takes first place. It's the commonest killer. And And you wonder again why. So there's much we can do about this, isn't it? So we need to work together so that we can improve these statistics and save our women. So the 2030 target as per WHO, in terms of cervical cancer elimination strategies, to achieve at least 70%. So we've talked about the 90% of girls to be vaccinated. So today I want to concentrate on the 70% of women who are to be screened with a high performance test by the age of 35 years, and again by the age of 45. And when we say a high performance test, pretty much what we mean is HPV. And then again, you go to the treatment and you have 90% of the women identified with cervical disease. And this is pre-invasive disease as well as invasive disease. So get the diagnosis early and offer these women early treatment. But we cannot achieve that if we do not screen the women, if we do not vaccinate the girls. So if we are able to achieve the 90, 70, 90 targets by 2030, then what? So we look forward to saving over 62 million women by the year 2021-20. So imagine the gift you can give to your grandchildren, your great-grandchildren. For us to be able to talk of pre-invasive disease, I know my colleague has talked about screening, so I'm not going to dwell much on that. But for us to be able to do what is needed in terms of treating these women who develop pre-invasive disease, then we must have a robust screening program in place. But how well are we doing? So if you look at the women who are 25 to 49 years of age, so we've had some sort of improvement. So you can see 5% in 2018 to 30% in 2024. I mean, it is some improvement, but it's not as expected, because we want to get to the 70%, isn't it, by the year 2030. But if in the span of 6 years, we've only been able to go up by 25% thereabout, then we have a whole lot of a problem in our hands. Again, when you look at the women that we've been able to screen, almost half of them who've had a positive screen did not receive treatment. And this is according to Kenya Health Information System data, 2024. So when you screen, it's not about the screening, it's about screen and then be able to offer treatment. If you're not able to offer treatment for 1 or 2, 3 reasons, then are you able to refer these women? Do you have a referral pathway in place where the women you screened, if they turn out positive, can receive treatment? Again, you ask yourself, who should be screened? So my colleague has talked about this, so I will not dwell on it. But important to note is that for women who are 25 to 49 years, when you're screening them for cervical cancer, again, give them the chance, offer them integrated screening together with clinical breast exam. One of my mentors would tell you, and most of the gynecologists here would be aware, that when you're screening these women, touch the breast and see the cervix. So if you're able to touch the breast, examine this woman wholesomely, and then go down and see the cervix. What do you see? Is it normal? Is it abnormal? Acetic acid is widely available, so it should be easy to at least offer these women visual inspection methods. But then I also want to caution you, because I met, we had an NCCP training last year in Voi, and we met an elderly lady who had been screened less than, I think, 6 months prior. But then she's come with advanced disease. And you wonder why, because she was screened, she had a visual inspection method. She's 60 years. So then you need to know who to screen and what modality of screening to use. Because if you offer visual inspection to a patient or to a woman who is postmenopausal, then you end up with patients who have disease lacking inside the canal. Because sometimes you have tumors growing inside the endocervical canal. You look at the cervix, it looks very normal. You apply your acetic acid, you don't see much. But then eventually they come back with a lot of disease and you wonder why. Oh, she was screened 6 months ago. So why does she have a stage 3 disease? Why does she have a stage 2 disease? Because you've not offered the appropriate screening modality that she needed. So when you offer these women screening, know what to offer. Know who to offer visual inspection when they cannot afford. Know who to tell, yes, I want to offer you this, but it's not the appropriate screening for you. And try and find them a way to get screened appropriately. But then why do we screen? Why do we prevent? Because eventually it becomes very expensive, it's complicated, there's loss of reproductive function. You can imagine, we get young girls. I had a 16-year-old a few years ago with cervical cancer. So when you put them through surgery and they end up with a radical hysterectomy, even if you spare the ovaries, if this patient ends up with radiotherapy, then many times they lose that little reproductive function that they would have been left with. And then you cannot imagine the impact on emotional and sexual health that these women go through, be it after surgery, but especially after radiation. Again, it's good to remember, most of these women are young mothers. They have young children. So you can imagine, by the time you're done with them, you've treated them. Who are you sending back home? So screen, 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 and vaccinate. Again, it's always good to remember that the road to cervical cancer is very long for some, fortunately, but some are not that fortunate because sometimes you find women who have faster progression for 1 or 2, 3 reasons. So they don't have that whole 10 to 30 years. Some of them have less years. But what is important is once you've screened your patient, then you come to the diagnosis. In your setup, are you able to offer colposcopy? I know NCCP has done a lot in terms of offering colposcopes. We've done a lot of trainings around the country. So most of you are able to do biopsies, especially the nurses, the clinical officers. You're able to biopsy. You're able to tell whether the cervix has disease or not and refer these patients or treat them appropriately as expected. So once you've done your biopsy, then you're able to figure out, does your patient have pre-invasive disease, yes or no? But then once you have pre-invasive disease, what's the future like? So if you have a CIN1, for example, which is a low-grade lesion, usually these are benign lesions. They would regress within 2 years. But then it's important to note that you need to follow up these women. You don't see a CIN1 and then say, oh, you know what, it's not a high-grade lesion. So then she's out of the, she's out of trouble, and you let them be. Because remember, at the end of the day, they still have that 1% risk of progressing to cervical cancer. So you need to follow them up. For women who have high-grade lesions, the progression to cervical cancer is way higher. So you need to always offer them treatment appropriately. Once you screen these women, there are some who don't have the luxury to, say, for example, have multi-visit. There are some who don't get that multiple visit where you're able to screen and then take a biopsy and then treat. Many times, because of in our setup or in other LMICs, most of the times the women, when they come, there's loss to follow up. They don't come back for 1, 2, 3 reasons. So when they come to you, it's an opportunity to actually screen and then offer them treatment in the same sitting so that you don't have a patient coming back with cervical cancer eventually. But for you to be able to do or offer a screen and treat approach, then you must be able to work with your program managers, with your MedSops, with your CEOs. You must be in boardrooms where decisions are made so that you can make decisions for your women. Because if you don't have a screening program in place, then what will you offer your women? There isn't much you can offer. If you have a screening program in place, then you can, offer these women HPV, you can offer these women cytology, depending on what you have. But when you don't have that, then you come down to visual inspection alone. And remember the 60-year-old I talked about, who you will offer via alone, and then what will you do with her? She has a type 3 transformation zone. So to begin with, you shouldn't even offer her that via. But what do? You don't have any other screening modality, or she cannot afford. So you let her be. And then eventually she comes back with a stage 3 disease. So for most of the young women whom we are screening, if you don't have a screening program in place, then you should be able to do a visual inspection method, whether you're doing a via or billing. depending on what is available in your setup. And then you should be able to triage these women up to either ablation or excision. Ablation doesn't necessarily mean cryotherapy, and excision doesn't necessarily mean LEEP. So we'll talk about that and see who we can offer what, who fits the criteria for ablation and who doesn't. But if you have a screening program in place, then you have all these other opportunities where you're able to offer your patient either HPV, offer your patient cytology. If not, then you offer them what you can as long as you've screened. When it comes to treatment, you need to be able to perform the procedure effectively and then safely as well. So for you to be able to do that, you need to have knowledge of anatomy. If you don't know how the cervix looks like, if say you don't know how many epitheliums are there, if you don't know where your columnar epithelium ends, if you don't know where your squamous epithelium begins, if you don't know how your transformation zone should look like, if you don't know whether the transformation zone is synonymous with the squamocolumnar junction, then it becomes difficult to treat. So you must have appropriate knowledge of anatomy. You must know the knowledge, you must have knowledge of disease process. And then you must be able to perform colposcopy. Again, I know most of the healthcare workers in different centers, especially if you're a CHI center, then you have a colposcope and you're able to perform colposcopy and map out disease. Again, when we come down to morbidity, we always forget the psychological morbidity. Always take consent. Talk to the women. Tell them, this is what I want to offer you. I want to do LEEP for you. I want to ablate you. This is 1, 2, 3, why I want to do this. And talk to them, hear them out. Because if she's lying on that couch and you go ahead and LEEP or, ablate, you've not talked to her adequately, you leave behind a patient who has a lot of psychological morbidity. But then once we've screened and we have a patient who has disease, then how do we treat? And this is pre-malignant disease or precancerous lesions. You have the choice of offering them expectant management, but you need to know who to offer expectant management. So these are women who have CIN1, you can expectantly manage them. When you have patients who have CIN2, CIN3, then you're spoiled for choices because you can either offer them ablative therapy. This is where you destroy the abnormal epithelium. So you have, in our setup, we're able to do ablation with cryotherapy or thermal ablation. And I'll talk about which one is commonly used as we speak. But in the more developed world, they're able to do laser that we don't really have the luxury of. The other option is to offer them excision. So when we talk of excision, you can offer them conization. Remember what I said, that excision is not, LEEP is not synonymous with excision. So you can do a cold knife cone, you can do LEEP. In some circumstances, you may offer hysterectomy, but most of the times we frown upon offering hysterectomy to women who have pre-invasive disease for 1, 2, 3, 4 reasons. You want to be able to excise the lesion, get the margins, have negative margins before you offer this women hysterectomy. Many times you don't know what lacks beyond your excision margin. Now, a lot of gain has been made in the treatment of precancer lesions, especially in our setup in Kenya. And we've had a major shift from cryotherapy. So you can look at this. This is on my left or on your right. So you have a large cylinder. They're usually heavy. They are expensive. The gas doesn't come cheap. So you have to keep on refilling. And then you have all these not so attractive, very, very bulky instruments. And the shift to thermal ablation, you can look at this nice, beautiful to look at gadget. It's handheld. You can carry it to the clinic. If you go for outreaches, and I know especially we usually have AMPATH clinics where we're able to go and offer ablation or LEEP, then we're able to carry this around with us. It's battery operated, so you don't really have to have electricity. If you have 2 batteries, if you've charged your batteries, then you're good to go. And it's very easy. It's really nice. It's attractive compared to what we've had before. And it comes quite cheap eventually. Again, this is just a better picture of the thermal ablator. And the reason I want to insist on thermal ablation is because cryotherapy has become a little bit obsolete right now. And what we use is more of thermal ablation. So you have all these instruments that come in the pack that comes with the thermal ablator. You have the thermal probe that comes insulated. So if you use the Liga, so this is a Liga. If you have the WISAP, again, it comes with a separate vaginal protector, but this one comes inbuilt. So it's really nice. You have all these buttons that you can control. You don't need to set the temperature. It is really attractive and it's really nice. So if you don't have a thermal ablator in your setup, this is the time to look for one. When we talk of ablation and excision, who is eligible for what exactly? Who do you ablate? Who do you excise? So when you're ablating patients, you must have a white lesion. So you must be able to carry out a VIA. You must know what is normal, what is abnormal. So then once you have an acetowhite lesion, you have to have a lesion that's within the transformation zone. You have to have a lesion that's not extending into the canal, that's the endocervix or the vagina. And then again, your lesion must be small, less than 75% of the transformation zone. To know that, you must know how a transformation zone looks like. So practice, get to know what is a normal transformation zone. You must be able to see the entire transformation zone. Remember the 60-year-old I talked about. If you have a transformation zone, if you have a type 3 transformation zone, meaning that your transformation zone is in the canal, you're not able to see what's really going on. You cannot see your lesion, it's not visible. So then you cannot ablate. So you must see what you want to ablate. There should be no evidence of invasive cancer. Never ablate a cervix that probably may have invasive disease. Again, your patient or your client should not be pregnant. They should have no vaginal infections. They should have no cervical infections. You must get a consent, whether it's a verbal consent or a written consent. Always talk to them, talk to them, talk to them. When you do ablation, you get limited because most of the times you don't get tissue that you'd get when you do excision. And then again, if you have a lesion that's extending into the canal, remember you're only allowed a tiny 2 to 3 millimeters, but then that you can also leave for the experts. But if you're not quite comfortable, then never ablate lesions that extend into the canal. So that is an inadequate bit. And then there's also that aspect of treatment failure, but it's not much. Of course, there's some complications, just like any other procedure. Hemorrhage is never really found in ablation, but you may sometimes have some little spots here and there. Quite commonly, what you have is a watery vaginal discharge. You need to talk to the patients, let them know that eventually that's what they'll have so that they don't keep coming back and saying, oh, I have a lot of watery vaginal discharge. And they think, you know what, they say, oh, I haven't, the place is infected, I have a lot of discharge. So you need to tell them upfront that you're going to have a lot of watery discharge. They may experience some minimal pain. And again, always expect to have some sort of vasovagal reaction. So you need to talk to the patients, talk to them, talk to the women. What does WHO recommend with regards to ablation? Use ablation over no treatment. If you have a patient, you can see a lesion, you don't have any other mode of treatment, you don't have LEEP, you cannot do a cone, please ablate. But in setups, so you're able to offer LEEP, you're able to offer a cold knife cone, then you can go ahead and offer that. Again, for women who have lesions that are over 75% of the transformation zone or extending beyond the tip, then that is the cryo or the thermal tip, then these are women you want to probably offer excision. Again, for women whom you've treated, you need to talk to them. You need to tell them they need to abstain. For those who cannot, a minimum of 4 to 6 weeks, then usually advise them to use a protective measure, and they can use condoms. If you have them at the clinic, you can offer them, but advise them on abstinence. Many times they don't abstain, so always please talk to them. There should be nothing in the vagina, no coitus, no fingers, no hugs. In my community, many times the women would put some sort of roots called tira in my language. I've also seen it among the Kalenjin. They also have some herbs that they put in the vagina for healing for whatever reason. So always talk to the women and tell them, don't put herbs, don't put soap, no douching, no nothing. Expect some watery discharge because of the sloughing. We talked about that, some cramping. But if they have fever, if they have a foul-smelling discharge, if they have severe pain, heavy bleeding, kindly talk to the women, let them come back. How do you follow them up? In 6 months, at 12 months, when they come back, please, please, please know where the stromocolumnar junction is. If you're not able to see one, then don't offer a visual inspection method. Always offer them either a HPV, a pap smear at that 6 months. But if you're not able to see the SCJ, remember, don't offer a visual inspection method. Again, just briefly on excisional methods. So commonly what we have is a LEEP, which is a loop electrosurgical excision method that uses a thin wire. Commonly, most of you are probably familiar with it, and we use it to remove the entire transformation zone. Remember, you're not doing a biopsy when you're doing a LEEP. You're taking the entire transformation zone. Through my IGCS trainers, I had the opportunity to visit Zambia last year, and it's quite interesting. They have clinics that are run by physician assistants or clinical officers, whatever you like to call them, or the nurses, and they're called LEEP clinics. So when they introduce themselves, they say, I am a LEEP provider. And they have quite a number of LEEP clinics. And it's the nurses who do the LEEP. They do it so fast, they're used to it, and it's very different from our setup. So I think with time, hopefully we'll get there, where we are able to offer these procedures frequently and often. Remember what I said, more than 30% of the women we screen don't get treatment. The beauty with LEEP is it can be done for both diagnosis, because you get tissue unlike ablation, and it's also for therapeutic purposes. Even when you have patients who have say CI3, or you're not able to do a cold knife conization and you're able to offer LEEP and they have a 1A1, then LEEP usually can be both diagnostic and therapeutic, but you need to be very careful with the margins. Again, eligibility, pretty much almost the patient you cannot offer ablation. Many times you can offer them an excisional method. So lesions that extend into the endocervical canal, commonly those ones we prefer to offer them conization, but if you're not able to offer, then LEEP comes handy. There should be no evidence of invasive cancer. There should be no glandular dysplasia. Those are women you want to offer a cold knife conization. Your patient should not be pregnant. There should be no history of bleeding disorder. Always talk to the women, take history. Sometimes you do LEEP and then you find your patients are bleeding profusely because you've not talked to them, so you don't know she actually has a bleeding disorder. And most of the times the clinics don't have much to really control the bleeding, especially when you go outside teaching hospitals, then there's a lot of trouble. Again, a written consent or a verbal consent. And remember, women who say you cannot rule out microinvasion, women who have glandular abnormalities, these are women you want to offer cold knife conization and not really a LEEP. Again, remember what I said about the margins. Most of the times the margins are charged, so these are women you want to offer a cold knife con. So this is an attractive again LEEP electrosurgical unit. That is commonly given by NCCP and CHAI. Most counties have this, so if you have this, it comes quite handy. You can carry it around, you can go with it to the clinics. Very easy to use, very nice. And most of you are trained on it, so we've done a lot of trainings on this, so it's easy to just place, it's like a mat place, go ahead and it comes with a battery, so you really don't need electricity if you have your batteries already charged. So it is a nice, attractive machine. So if you pair this with your thermal ablator, you're good to go. Again, in most setups, we don't have the luxury of this beautiful small machine. Like in my setup, this is what you get. But then you do what you can and LEEP your patients or treat your patients. So at the end of your LEEP, this is what you should have. You should be able to have loops of different sizes so that you can offer your patients the appropriate treatment. And also you should have a ball electrode. Many times you don't have one cell solution, but if you have a ball electrode, that should serve as a mode of achieving hemostasis. Again, instructions post-excision, the same thing that you'd tell the women you've offered ablation, pretty much the same. When you have patients bleeding, then what do you do? So remember what we said. So you can fulgurate if you have your ball electrode. You can do hemostatic sutures. This becomes a little bit difficult in most clinics. You don't have this. You can pack with a vaginal gauze, but just make sure the patient doesn't go home bleeding. A Moncell paste comes really is quite helpful. Many times it's very expensive, but if you're able to talk to your local pharmacy, then they should be able to prepare some for you. Again, like any other procedure, there are some small side effects or complications that you should expect. Commonly, what we have with lip is bleeding, especially if you go very deep. So you have to be very careful when you do lips, observe quite a number, then, you know, under guidance, do a few. And with time, you get you get the hang of it, and you're able to do the lips. Commonly, there are no issues in terms of fertility. There's a less than 1% risk of stenosis, really, but we've not really had much issue with the patients we've offered lip. So I've been asked to mention 1, 2, 3 things about cervical cancer. Again, remember, women who present, you've missed the screening, they will not come with any symptoms. Most of the times they come with nothing. They don't have any symptoms. So by the time the patient is coming with symptoms to you, this is a patient who has advanced disease, so no symptoms at all. At times, the patients may have some postcoital bleeding. They may have postmenopausal spotting. So if you have any patient who is bleeding, whether they're premenopausal, postmenopausal, kindly take a look at the cervix. Remember what we said, touch the breast and see the cervix. Any abnormal bleeding needs to be investigated for any patient. And again, as the disease progresses, then you have all these signs and symptoms of advanced disease. So you have persistent back pain, you have leg pain, you have weight loss, you have foul-smelling discharge, and many times they don't have anything. They come to you stage 4 and you know, they've never had any, they've never been symptomatic. So diagnosis is made, you have to have you have to be able to do a biopsy, take a biopsy, get a histological confirmation, then do the staging. So you initially start with your clinical staging, and then eventually progress to radiology, be able to offer the appropriate metastatic workup so that you can look into the spread of the disease. And then in terms of treatment, just briefly, so we have a number of modalities that you can offer the patient depending on when they present. So commonly, if your patients come early, then we're able to offer surgery. But then the problem with surgery is many times the patients come with stage 3, they come, you know, stage 2, and they ask, can I get surgery? Can I have surgery done? Can I have, you know, the uterus removed, the womb removed? And then you ask yourself, how? These are young patients, 30-year-olds, 25, 26-year-olds, they have young children, but they miss the opportunity to get screened. They've never been to, you know, they've never been to any screening clinic, really. So now they come, you cannot offer them much in terms of surgery. So for you to offer them surgery, you'd stop at stage 1B, 2. And commonly, these are patients who don't have much of gross lesions on the cervix, hence the importance of screening. The other modalities are radiotherapy, chemotherapy, and again, palliative care is an essential element of cancer care. So it doesn't mean that the patient has to get to stage 4, stage 3, stage 2 for you to offer them palliative care. Offer them from the word go. If your patient comes with 1B1, concurrently, as you manage, offer them surgery, radiotherapy, chemotherapy, also offer them palliative treatment. So in conclusion, remember that cervical cancer is highly preventable through both screening and vaccination. And remember that prevention goes hand in hand with screening. So screen, get screened, screen your neighbors, screen your friends, and get vaccinated. Thank you.
Thank you, Dr. Amina, for a wonderful presentation. Just to inform, in case you have any questions, please go to the Q&A. We are actually replying as you ask your questions, and we'll also answer live at the end of the presentation. I'd like to welcome Rose Nyaboke, who is going to be our third speaker. Rose Nyaboke is a global health specialist with a clinical background. She has a master's in global health and currently pursuing her PhD in health systems strengthening. She also has done short courses in reproductive health and lately trained and certified on lip colposcopy treatment. She is working and supporting the coastal counties under CHEB Kenya, which is under USAID, Stawisha Pwani. So let's welcome Rose.
Thank you, Doc. Good afternoon, everyone, and kindly share the presentation.
We are sharing right now. Give us a minute. As the technical team is doing the presentation, is sharing the presentation, I'd like to remind us to go to the Q&A and ask questions. We'll be answering the questions online, and also we'll do a live session at the end of this presentation. So feel free to use the Q&A. And I've seen a lot of questions on vaccination. I will take those ones. Thank you.
We don't want to refer clients. So how do we make sure that we screen a number in the facilities? And also when we go to the outreaches at the community there, we are able to get women and, rather than referring them to the facility, they are able to be screened at the community. And even using, like the medical camps, reach as women, as men as you can. The second one is single visitor approach. This is facility and community. You know what we are doing when you talk about single visitor approach, and thanks to the thermoablation machine, you can move with that machine everywhere you go. So when that patient comes to the facility, you are able to screen if the patient is positive, and you treat the patient there, and the patient goes home, happy. So that is what we call single visitor approach, where a client gets screened positive and get treated. The other one is about harnessing digital tools and also intervention, has the potential to improve different aspects of cervical cancer screening and also controlling, including telemedicine. And still, I want to give an example of Kwale County, where they're using, an AI to make sure that women are screened and they're able to see those abnormal cells. And then they have another test which they can be able to confirm either through a pap smear or via or even HPV DNA testing kits. Then we also have virtual online academies to reach as main healthcare providers. So if you are not trained, and then those are some of the consideration, and those are some of the things which are happening. Actually, we can be able to get virtual and those online, seminars and trainings, and we learn as compared to hotel-based training. And the last one is about AI technologies for cervical cancer screening to detect lesions early and prevent future cervical cancer. So my last slide, by implementing a comprehensive approach that combines system-wide integration, patient education, provider training, and addressing potential barriers, some of the stigma, and also the myths and misconception, and addressing potential barriers, primary care setting can significantly improve the uptake of cervical cancer screening and also contribute to early cancer detection. So that is my message today. Let's not fear integration. Let's make sure that we integrate so that we can be able to give the services for our women. That small change matters. Let's screen and treat. You will make a difference for that woman, that child, and save her life. So, and I also want to acknowledge the National Cancer Control Program, the Education Committee, where I'm also a task force, one of the task force committees, CEP Kenya, USAID Stawisha Pwani, the Ministry of Health, and also the counties represented, implementing partners, and also other stakeholders. We work with other stakeholders, and also the healthcare workers, fraternity, and communities in general. I want to say thank you, and this is my last slide. So cervical cancer, you can't afford to stay ignorant. Let's make sure that we reach to all women.
Thank you very much, Rose. Now we'll go to the question and answer session that will not take a very long time because we are already at 3:31. But most of the questions have been answered in the Q&A area. I'd like to start by answering somebody who's asked. There was social media clip by a Kenyan doctor advocating against the HPV vaccine to Ugandan president. His claim was that it's laced with a contraceptive that caused difficulty in conception. Any comments? So on that issue, the Ministry of Health, through the National Quality Control Laboratory, they actually conducted tests on these vaccines, and there were no hormones that were laced in these vaccines. And this vaccine is safe and effective. So thank you very much for that question. I'd like to now go to Dr. Amina. There are several questions that have been asked. Can a woman have postcoital bleeding with a negative villi and negative pap smear? If there is, what could be the cause of bleeding after intercourse? Then there is also another question I'll also like you to answer. For pregnant women, up to how many weeks do we do screening? Dr. Amina?
Yes, thank you, Dr. Mfua. So the first question on a woman who is bleeding, but then the visual inspection method and the pap smear, the cytology are both negative. So first we need to know that if she's bleeding, you need to know why she's bleeding. There are many causes for uterine, cervical, vaginal bleeding. So does she have fibroids? Is she an older patient? If we've done a pap, then do we know what's going on with the endometrium? Could she be having endometrial cancer? Does she have an infective process? Does she have a bleeding disorder? There are many causes for bleeding. So it doesn't necessarily mean that if you have a normal VIA or a normal PAP or even a normal HPV, then you should not bleed. If she's a young patient, she could be pregnant. So it's a little bit difficult to tell why one would bleed, yet they have a negative screening done recently. So unless that patient or that client is reviewed and examined by a healthcare worker. So I'd advise the person who is asking to visit a nearby clinic so that they can get adequately examined and investigated. Then the next question was on screening in
pregnant women. Yes.
So again, screening is very important. If you've never had screening done, so regardless of whether you're pregnant or not, then you should get screened. The challenge with the screening, so the challenge with the screening in pregnancy is we advocate for screening at least up to the first prenatal visit or the end of it. So by the time you're getting to 12 weeks, you should have had your screening done. So the challenge with, if you're offering a screening modality like HPV, then there's no problem. You can screen throughout the pregnancy. It doesn't change much. So the challenge we have with doing a visual inspection method or doing a pap smear during pregnancy is they're usually there are changes that occur during pregnancy, and these changes may be interpreted because of hormonal changes, and these changes may be interpreted wrongly. So commonly what we'd advocate for is to get screened outside of pregnancy. If you've never had any screening done, then kindly get screened during pregnancy. If you're able to go to someone who is very familiar with the cervix, if you're able to see a gynecologist, then even better, because they're able to tell what is normal and what is abnormal. So is it recommended during pregnancy? Yes. But up to 12 weeks beyond that, then we have to be a little bit careful with how we interpret what we see on the cervix or how we identify abnormalities, because sometimes you can see something and think it's probably cervical cancer or a premalignant disease, yet it's just due to hormonal changes because of the pregnancy. So it has to be interpreted well. Thank you.
Thank you, Dr. There are quite a number of questions on HPV vaccination. Let me take up one and then we can go to the rest of the questions. So can we consider boys in HPV vaccine? As I stated earlier, currently the HPV vaccine in Kenya is targeted to the girls. We have not yet managed to reach the girls. And the reason why we are vaccinating the girls is because as you had seen Dr. Amina's presentation, CA cervix is the second leading cause of cancer in Kenya, and 75% of the cause of CA cervix is secondary to HPV infection. So that is why the target is the girls. For the boys, yes, other countries who are well off compared to Kenya are also vaccinating the boys, but currently for the programmatic, the government one, it is only targeted to the age of 10 to 14, but you can also actually get it if you have a son or a young child, a young boy who you'd like to vaccinate you, but you can vaccinate but outside the government program. And this is basically due to the funding aspect. It has nothing to do with the physiology. So on physiology, if you're able, please do vaccinate. But as a program, current target is the girl child between 10 to 14. Then other questions on the question to Kennedy, do we screen antenatal clients?
Yes, thank you very much, Dr. Julia. I think antenatal, no, we screen up only the first trimester. But again, what we want to advocate for is that we just leave, postpone this screening. I don't think whether it is very urgent to start interfering with the pregnant mothers, unless if there is something pressing, but we will only consider up to first trimester. Remember, we only have 9 months, and even if it was a small lesion, 9 months is a very small period which we can still wait and attend to this woman post delivery. Thank you.
Thank you, Kennedy. Then there's also a question on HPV on the testing. So I'll also like to take up that one on the HPV testing. So the question is, great presentation, HPV being the primary screening test, are there any efforts at the national level to reduce its cost and make it more available to our patients? So I can actually currently say that Ministry of Health has acquired reagents for HPV testing, and it is currently at the National Oncology Reference Laboratory that they are able to test, and some various labs that we are trying to take the reagents to them. So currently we are able to test, and it is currently free. The collection kits are actually being taken to the counties. So what you can do, you can go to your county referral hospital and request for the HPV test. Then it can be transported to the national government, National Oncology Reference Laboratory for testing. So currently, yes, we are able to do that, and it is currently free. So please, 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 this February, let no one, let us go and request for that test. If the facility is unable to do it, let them reach out to the NCCP team and see how we can take, they can get the collection kits. So right now we have quite a number of test reagents for the same. So I'd like Dr. Amina once again, kindly comment on treatment of HPV infection. Then the second question is, how do we manage cervical prolapse? Actually, this question has nothing to do with today, but please, Amina, you can answer.
Thank you. So we don't really treat HPV. It's a screening modality. So once you have a HPV test that's positive, then you want to first know what HPV virus do you have? Is it a low risk type? Is it a high risk HPV type? Then if you have a high risk HPV type, then you probably want to get in touch with your healthcare giver so that you can be triaged to having a colposcopy done. Because if you're able to get a colposcopy done, then that is usually the appropriate measure. Then for whatever reason, if there's no colposcopy available, then there are other methods like VIA that can be offered to you, a biopsy. It all boils down to what kind of HPV test result do you have. Then the second question on cervical prolapse, I don't know if the person who asked the question meant cervical cancer, or she just meant a uterine prolapse. Then again, if you have a uterine prolapse, you need to seek care, see your gynecologist near you. Then they're able to offer you the appropriate treatment, be it surgical or non-surgical, depending on what the patient has. If you're talking of cervical cancer, then that's a totally different story. Again, kindly seek care so that if there is a lesion on the cervix, then you can have proper staging, biopsy done. So I think that answers both. Thank you.
Thank you very much. I'd like to thank you all for attending this session. And thank you all for those who have asked questions, and we managed to answer most of the questions that you asked. And the questions on CPD, this is a KNH organized webinar, and it is through the KNH portal that we get our CPD points. So long as you actually registered and gave your correct details, you will get your CPD points direct to your portal. For doctors, and for others, you will get the CPD points. So thank you once again. I hope I have not locked anyone from my Q&A area. We have answered most of your questions. We have answered more than 53 questions, so thank you very much. So kwaheri, and may we see you another time. Thank you.